Good afternoon, everyone. Good afternoon. Welcome to the Fall 2021 Distinguished Biomedical Lecture at Chestnut Hill College. I'm Chris Doherty, Vice President for Academic Affairs and Dean of the Faculty, and I have a few informational items for you before we begin today's event. As speakers present from the podium, we will be unmasked, observing the standard that we have 12 feet of distance between an unmasked speaker and others in this space. As we complete our comments or are joined by others at the podium, we will remask. Today's presentation is being recorded, and we will be sharing the link to today's presentation with the broader community for the benefit of those who could not join us here today. And we are so delighted to be here present today with us. Our experience this afternoon is very much about legacy. The legacy of Sister Carol Jean Vale's leadership and vision as president of Chestnut Hill College. The legacy of the Biomedical Distinguished Lecture Series, which under the leadership of Dr. Lakshmi Atchison has consistently engaged the Chestnut Hill College community in timely and critical conversations about research, innovation, and practice in the basic and clinical sciences. And celebrating the legacy of Chestnut Hill College students and alumni, truly ready for any good work, and exemplified by our speaker today, Dr. Aisha Gayas. It is my distinct pleasure to introduce to you Dr. Lakshmi Atchison, Professor of Biology and Director of the Biomedical Lecture Series.
I hope I don't cry. Thank you, Chris, for your kind welcome remarks. I greatly appreciate it. Good afternoon, everyone. Thank you all for coming to our Chestnut Hill College. I meant each and every one of you. Thank you for coming here. To all our visitors, if you are here for the first time, we are delighted to have you with us. If you are a second-timer, we are very happy you are back with us. If you are an all-timer, we are super happy you are stuck with us. I am delighted to have our alumna, Dr. Aisha Gayas, as our 28th Annual Biomedical Distinguished Speaker. At the outset, I want to thank the Dalbello family, Al and Denise, for being here. Al is here. Al is Aisha's older brother, who enrolled Aisha back in 1996. In Eastern culture, you obey your elders, you obey your parents, you obey your teachers, and you obey your older brother. When Al brought Aisha to Chestnut Hill College, he said, "This is where you are going." That is a command. Aisha obeyed and said, "Yes, brother, this is where I will go. Chestnut Hill College is for me." And the rest is history, and it is a happy and a successful ending of Dr. Gayas. Al, would you please stand up to be recognized? Dr. Joseph Kolkowski, one of the best, my colleague, and his church colleagues, Reverend Lisa Thomas and Todd Thomas, have a very small, brief musical to welcome Dr. Aisha Gayas.
Dear Dr. Gayas, we have a special tribute for you today in appreciation for your participation in our biomedical seminar series organized by our own beloved Dr. Lakshmi Atchison. You are our third alum to have graced the podium to deliver a presentation in this series. Given your clear love for this college, we have special words to a very familiar tune that you will immediately recognize. Please enjoy our musical tribute. Thank you so much, Aisha, for returning to the college and inspiring our students.
We love thee, dear Aisha. We're grateful you are here to share with us your knowledge, to us for whom Welcome Aisha. She is a great alum, a most distinguished doctor, in whom we are so proud, in whom we are so proud. One of our own from Chestnut Hill.
Dr. Gayas will be speaking on a very timely topic. She was in the front line in 2020. Treating patients dying from COVID-19. While people were running away from COVID patients, she ran toward them, held their hands while they were dying. Dr. Gayas has many gut-wrenching stories from a clinician's point of view when humanity was in crisis. Her stories will touch everyone's heart today. Dr. Gayas is not new to Chestnut Hill College. She graduated as a double major in molecular biology and biochemistry and minored in math. As you can see her before and after pictures, microscope versus stethoscope. Before, Aisha was the face of Chestnut Hill College, and now she is the face of humanity. What an amazing transformation. Her academic resume is superb, with stellar reputation. While at Chestnut Hill College, she received many honors and awards. She also did an outstanding honors thesis in molecular biology at the University of Pennsylvania under the leadership of my husband, Dr. Michael Atchison, and won many awards for this college. All these awards she won by doing research. Subsequent to her graduation, she received 2 master's degrees, Master's in Medical Science, Master's in Public Health from Arcadia University. She also received certificate in marketing management from Wharton School of Business at the University of Pennsylvania. In addition, Aisha also did a research assistant and did cutting-edge research in molecular biology under the leadership of Dr. Michael Atchison at the University of Penn, and published a paper in leading journal in molecular biology. She also published a paper with Dr. Mary Daly, who was one of our distinguished biomedical speakers. Dr. Daly is a leading breast cancer specialist, and she was one of our, and also Dr. Michael Atchison was one of the biomedical speakers. Dr. Aisha is now actively publishing papers in clinical research. As you can see this slide, this is just a partial list of her publications. Dr. Gayas is a people's person. She went on to earn her physician assistant degree and was board certified, and she practiced as a physician assistant for over 10 years and gained extensive knowledge in interventional radiology. She also affiliated with 8 different area hospitals in New Jersey and Pennsylvania. In addition, she has many other credentials to her credit. Aisha has a true passion for medicine, so she went on to receive her medical degree from MD from beautiful St. George's University School of Medicine, where the rigor of the medical school is very intense. She passed with distinction, magna cum laude. She has now completed 2 of her major American board exams, Step 1 and Step 2, and currently Dr. Gayas is specializing in internal medicine and will continue her fellowship in pulmonary critical care. Dr. Gayas has done great amount of volunteer services, as you can see in this list, from 1999 to this date. This was well known even when she was at Chestnut Hill College. Dr. Gayas also has numerous affiliations with organizations and hospitals. There is a huge list. I'm just showing you a partial list here. Over the years, Aisha has earned so many degrees. You know, my little English knowledge tells me there are 26 alphabets in English language, and she has taken 14 alphabets and put them next to her name. Go figure. She is highly driven. She has multiple degrees. She speaks multiple languages. She has good knowledge and computer skills and has many other talents. On a personal note, Aisha tells me that she will go wherever God will take her, and she will serve there. Service to the community is her motto. Wherever Aisha serves as a medical doctor, she will succeed. One thing for sure I know, that she will never forget her humble beginning which she all started at Chestnut Hill College. Thank you, Al, for bringing Aisha to Chestnut Hill College, which she proudly calls her alma mater. Aisha is loyal to Chestnut Hill College, where her ambitions, hopes, and dreams began. She is eagerly looking forward to completing her residency and fellowship and become a fellow of the American Academy of Pulmonary Medicine in critical care. Aisha, it is a pleasure to have you with us. You are very successful and accomplished, and yet you are very humble. And you have made many of us very proud of your achievement and taking time to come to Chestnut Hill College. Dr. Gayas must be back in New York by tonight. She just drove from New York, and tomorrow morning she should be back. She has a very grueling schedule as a resident doctor with many sleepless nights. After the lecture, there is a reception in the rotunda in honor of our president, Dr. Carol Jean Vale, SSG, and our alumna, Dr. Gayas. All are welcome to join the reception. I am very thankful to Dr. Christopher Dougherty, Sue Harkins, and all the staff members who has helped me for today's event, from bathroom to banquet. Thank you so very much. It is my duty at this point to extend my sincere thanks to Don Wisher and Greg Gorski for their hard work. And setting up this stage is not an easy task. They have such able skill and they are so dependable. The program will not be colorful without the help of Don and Greg. I'm truly grateful to both of you, Don and Greg. I can see you, but I thank you. Again, on behalf of our president, Dr. Carol Jean Vale, I thank you all for coming. Ladies and gentlemen, it is my distinct pleasure to introduce to you our 28th annual Biomedical Distinguished Speaker. Would you please join me to give a warm welcome to our alumna, Dr. Aisha Gayas.
Thank you so much for having me here today. I couldn't say no to Dr. Lakshmi. Nobody can. And it's an honor to be back at a place where I called home. And it was very hard to get over Chestnut Hill College. It took years. And it's a joy to come back and to be the speaker of this distinguished lecture series. And I was a student, and I joined in the last 4 years when I was here. I joined every single seminar while I was here, and I had the honor of being in the company of Nobel laureate as well. And it changes you, it inspires you. And that's done by Dr. Lakshmi Acheson, keeping in mind that it is all for students. It is all for education. It is all for changing the world. And I am honored to be here today to be part of this amazing legacy of Sister Carol's service to students, to education, and to humanity. And I am so thankful that I am part of this celebration. And most of all, Chestnut Hill College has been very unique from the beginning. It gave me a chance to become who I wanted to be. It empowered me to be a woman that I am today, to just follow your dream, and it gave me a chance. And this is the place where I met my lifetime mentors, Dr. Lakshmi Acheson and Dr. Michael Acheson. If it was not for them, I would not be here today. And students, before I start, I have a message for you. Really cherish your professors, cherish this place, cherish those who empower you, who challenge you, and who nurture you. And I'm an example, I'm here because Dr. Lakshmi challenged me to be here today. So thank you for all for being here. So let's talk about COVID. So I was a fourth-year medical student working in the emergency room when I got to hear that there is this contagious respiratory illness that's spreading. And I was in New Jersey in one of the hospitals, and director of the New Jersey hospital was really nervous. And every patient interaction that she had, she was gearing up with protective gears, including the mask and the whole gown. And I was shocked. Why is she doing that for every patient? At this point, we didn't know, and I didn't know certainly. And she was saying that she didn't want to be quarantined. And she shared that somebody at another hospital was quarantined for 14 days and they had been exposed to this contagious respiratory illness. My physician, ER attending that night, told me that she bought a large number of N95 from local Home Depot, and she's afraid that we will run out. And that night, she told me that you are going home and not staying in the hospital because we have no idea that this contagious virus is spreading like a fire. I was scared, and they told me that not to come back to rotation because it's so contagious and we want to save our future and our students. And also there is not enough protective gears to be used for the large number of infections that they were expecting. So I was really surprised by that. So I was a fourth-year medical student. Just during this pandemic, I worked as a physician assistant and as a resident at 4 different locations. So that night, I came home and I started looking at these numbers. And by that time, we're talking about March, and 500,000 people were already infected by this virus. So, and I was just starting to receive emails from my work, which I used to work on the weekends, that there is dire need of having clinicians to treat these unexpected numbers of sick people that are showing up in the emergency room, in the ICU. So, and I was not supposed to work until the weekend, so I was restless. I said, I had no idea that when I'm going back to school. And in the meantime, we received emails from work that, don't go to rotation until you hear from us. So now I'm sitting and looking at these numbers. I have 10 years experience of being a clinician, working in the ICU and interventional radiology. And I just could not just watch the numbers growing. So I called my supervisor and I said, hey, I can't wait for the weekend. I want to be there. I want to help out. What's going on? And luckily, I was working already and I had the privileges to work in the hospital. So that if she said, hey, I would love to come over and help out. So that night, I went to work. And this was my first patient. He was a 38-year-old male, owned a toy store, history of HIV, high blood pressure, and presented with worsening shortness of breath where he couldn't even talk. And I had to admit him that night. He was COVID positive. Here I'm showing you a normal X-ray. You have lungs, heart, and the spine in the background, and that's healthy X-ray. And this was his X-ray. You have these ground glass opacities, and this is typical of COVID-19. Imagine breathing when there is poor exchange of air and oxygen. And so this was my first patient. I was shocked, and we were directed to discuss goals of care with the patients because we knew that this disease is going to progress or get severe. This patient did not want to be intubated. So he told us that he would like the treatments that we have available and would not want to be on a machine that will breathe for him. And he passed away 2 days later. Before I knew, after my first patient, the number went up. We would have 20 patients from a nursing home coming in with respiratory illness, unable to breathe, unable to talk, all requiring oxygen or ICU level of care. So before we knew, by the weekend, we had turned our ICUs, our libraries into ICUs. Endoscopy suites were all ICU. So just I'm showing you here that normally a small 400-bed bed hospital would have, let's say, 30 medical ICU, 30-bed medical ICU. It went up to 80 to 100 numbers. So we had no place for ICU beds. So we went into the libraries and turned into ICU rooms. And we did not have enough manpower to treat these patients. So what we did, everybody became ICU competent. We cross-trained specialists who are, for example, urologists or podiatry. They came to help out and ran the ventilators and provided ICU level of cares. Nurses who did not never worked in ICUs, if there was a cross-training, we all helped each other out. There were times when we shared patients. My physician said, if you see the patient, then I don't have to see. There were times when our colleagues were sick and they couldn't see patients. Some colleagues had little kids and were afraid to get sick, so we had to share our patient load. One of my colleagues had 2 children, not children, but kids in medical school, and she's the sole provider for them. So we said, no, you're not going up front, we'll go and help out. So we all stepped up when we have to, and we had to. So the surge was really, really surprising to me during my 5th year, but I was glad that as a physician assistant, I was able to help. Then I want to visit here. I made an outline for you just where this all started and where I met my first patient. So as you can see, in 2019, December, we saw first case of, this is pneumonia in China. And early on, it was thought that it is just an atypical pneumonia. Nobody knew what it was. And then by January 5th, we have that that atypical pneumonia was actually COVID-2 coronavirus type 2. And then our first case that we saw in America was from Seattle, January 20th, and it had come from recent travel from China. Then by the time I saw my first patient here in March, and it was already a pandemic, CDC had called it pandemic. By January 2021, from March to January 2021, we all suffered. I don't have to share what happened. Schools were closed, we were under lockdown. Many grandparents didn't see their children. Children didn't go to school. There was a lot of sadness around this time. But we did see vaccination that were available to us. And then, regardless of vaccination availability and hindrance to its delivery, we saw new strains before September. And then by September 2021, we have 40 million people already infected in the United States. So this was really neat that I came across that CDC and WHO actually made apps, WhatsApp, that had the ability to reach 2 billion people throughout the world. And the slogan basically was that we can detect this, we can isolate, trace, and mobilize our manpower to face this infection. So this is another recent statistics here. We have 5 million people died from COVID. They did not have to die like this. We have 43 million people in America suffering from COVID. And COVID is not just respiratory it touches you at different levels, and it also has long-term consequences and symptoms as well. So let's talk about origin of coronavirus. So we have seen, this is not new, we have seen 3 pandemics, at least in my lifetime, that is caused by coronavirus. There are almost 7 genres of coronavirus. And the first pandemic that we saw was 2002 and 2004. And COV1 gene is very similar to COV2 gene, and there is 80% homology. And COV1 actually spread to 27 countries and affected almost 8,000 people, and 800 died. There is only 10% mortality, shouldn't say that, but 10% mortality with COV1. With MERS, we saw it in 2012. Last case with MERS was reported in 2020. And mortality with MERS is 35%, which is very high, also spread to 29 countries. And its gene, the coronavirus gene, is almost 50% similar to MERS. Their homology is almost 50%, as I said. The common thing that 3 viruses have, they all come from bats. And coronavirus has to have intermediate first, and then to spread to humans. So for COV1, is the civet cat is presumed. And for MERS, we all know it's camels, the intermediate host. And for coronavirus 2 is the pangolins and minks. But exact origin, we still do not know. There is an assumption that it came from a lab accident, or it was just an evolutionary origin. We don't know. The origin is still elusive, and there is a lot of research that's ongoing to figure it out where it came from. So, and then early on, there was a question, is it a droplet or is it an aerosol? So just to give you an idea, a droplet is that settles very closely, an aerosol that travels in the air. And so when we cough, right here, as you can see with the jet of cough, you could have particles and virus can settle in it. And these particles range from 0.3 microns to 10 microns. So particles that can settle in your lower lungs have to be less than 0.5 microns. So the size of the coronavirus is 80 nanomicron. So just to give you an idea, it can travel distance. It has the ability to be both aerosol and droplet. It all depends on the load of the inoculum. If the source is highly infective, and also your host susceptibility and exposure length, and also what kind of procedures you are doing. So for example, in hospital, if you are intubating somebody, putting a tube in their throat, and when you're giving them oxygen at a high volume, then it becomes an aerosol. And there are special precautions for that. So it's very important, as I show you here, that wearing a mask is the key. There were studies, which mask, and does it have to be N95? Any barrier will protect you. So mask is the key. So here I highlight a little bit of a cartoon for you, how coronavirus gets into the cells, propagates, and leaves the cell. So coronavirus has the spike protein. We are all familiar with it. It has to have a receptor to bind. And there are many enzymes that enhance that binding. And therapeutic modalities are being built to basically stop this interaction of the virus, its spike protein, and the enzymes. So basically, there's an ACE receptor. It also binds to different receptors, but mostly it's ACE receptor that we have in our mucosa, in our kidneys, in our GI tract, and in our heart. So the virus goes in, and it basically has an RNA. It's a positive RNA. It's the longest RNA virus that we know. And it basically takes over your cell, goes into your cytoplasm, and starts making its proteins, and uses cellular machinery, packages cells, destroys the cell, and goes on to destroy other cell. So the disease comes from the destruction that is caused by the virus. So what are the risk factors? And I highlight many of them. Basically, being a healthcare worker is a risk factor. Having history of being immunocompromised, for example, being on steroids or on biologics, having a history of transplant, living in close quarters, and having close contact with the infected individuals, kidney disease, diabetes, which is so prevalent, and having a higher BMI. What causes that still is elusive, but those are the many common risk factors of getting COVID-19. So what are the goals at an individual level and at a global level is to detect, isolate, and provide treatments that are not anecdotal, but evidence-based treatments. And prevention is the key. Hand washing, maintaining distance, quarantining if you're exposed or if you're infected, and most of all, I should have added here, vaccination. So COVID-19 has a spectrum of a disease. 85% of the time it is asymptomatic. And then it has two phases, ambulatory or being hospitalized. Ambulatory is when you're not hospitalized, basically you're as an outpatient. So you start symptoms from having very simple symptoms, cough, sore throat, but still being on room air, which is 20% of oxygen, 21% oxygen, and having but having shortness of breath on exertion, but not at rest, but still keeping your oxygenation higher than 94%. So when your imaging shows that your X-ray that I had shown you previously, if it is greater than 50% of the whiteout that we saw on chest X-ray or on CAT scan, if your respiratory rate is greater than 30, those are qualifications for being hospitalized. You and I, we breathe at 12 to 16. Sometimes we're anxious, 20. But if you're breathing into the 30s, you're really having very severe symptoms. And then as disease progresses, you are critically ill. And at that time, you see renal failure, you see heart arrhythmias, heart failure, and very, very severe presentation. So as I mentioned, we have simple, still, sickness, fever, chills, but then you have none of these. Patients are showing up with these. They are showing up with myocarditis, which is inflammation of the heart, coming up with pulmonary embolism, PE, deep venous thrombosis, DVT, renal failure. They're still basically making urine, but not know that their creatinine, a marker of renal function, which is supposed to be let's say less than 0.5, they're coming with 10, but they don't feel good. So you can't have none of these, but present with the hospital with these symptoms and signs, and underlying cause is COVID-19 infection. So early on, we had detection by PCR and antibody and antigen testing. So when people were coming in, we were assuming everybody has COVID. Early on, it used to take almost for 4 hours to 3 days or 3 days to get the results. So everybody was in isolation, and imagine that's why we needed more room to quarantine people. And as the technology progressed, and the testing became shorter and shorter, and we know now within an hour the results when somebody is infected with COVID-19. Oops. So how we treated patients in the hospital when they were inpatient, some patients, the disease severity depends, we sorted them based on oxygen requirement. So when they required just the room air, then obviously they were okay. But when they started requiring oxygen, 2 to 4 liters, that was a mild disease. So as the oxygen demand went up, we were able to provide 100% oxygen. As I had mentioned, you and I breathe at 21% oxygen, room air. So, and we are able to give patients not just oxygen percentage-wise, we can also give them large volumes of oxygen, and that seems to help with oxygen exchange. Early on, we had also some non-invasive devices, continuous pressure, airway pressure, and bilevel airway pressure machines, but the evidence showed that there was more morbidity associated with their use. So now what we do, we jump from high flow, high concentrated oxygen, 100% oxygen. If patients do worse, then go straight to invasive endotracheal intubation. And then evidence showed that if you prone patient, if you lie them on their belly, they tend to do better. And it doesn't have to be that they have to be intubated and then be proned. Actually, if they could be proned at any stage, and patients tend to do better when they're prone. Pathophysiology behind proning is you are able to recruit more alveoli, which are the unit of lung where you exchange oxygen. So proning, whether they're intubated or not, I just want to bring out, even though it looks very simple, imagine hundreds of patients, imagine the nursing labor and the team labor to prone patients. And I salute all the nursing, all the healthcare workers who make this happen even today. So it's labor intensive, but we see very good results. So as the disease progresses, you need more oxygen, as I had just mentioned. So we have treatments that are antiviral medication. I'm sure some of you have heard of it, remdesivir, antiviral that we had. And again, these treatments are based on evidence, not on anecdotal evidence. So early on, antivirals tend to help. But as the disease progresses, what you see is a highly inflammatory state where your own body basically causes the damage of the tissues that are already infected by the virus. So the evidence shows that as disease progresses, use anti-inflammatories, and those are available to us, and that's where the current regimen is. So we are giving steroids, which are anti-inflammatories, and we are giving medications, I will mention in the next slide, that are anti-inflammatories. So this is a protocol that I outlined here for you. Oxygen requirement goes up. Early on, we give remdesivir, which is antiviral medication. And as the disease progresses more, then you are given steroids and then anti-inflammatories, which is IL-6 inhibitors and JAK2 inhibitors. These are pathways. I have more scientists here, and I didn't go into detail, but just wanted to make it simple for all of us that these anti-inflammatories are really, the evidence shows they decrease mortality. And as mortality is decreased, your prognosis is obviously better. So that's the current state of treatment for COVID-19. So the inpatient treatment, as I mentioned, but there is outpatient treatment available as well, and many people are not aware of it. These are IV infusions. Anybody who has risk factors, simple as age greater than 65, they have lung disease or diabetes or kidney disease, or they are chronically vented, had PEG tube, which is tube for the nutrition. If they happen to be fine and get COVID-19, and they have a susceptibility for the progression of the disease, these monoclonal antibody treatments are available, and the evidence shows that patients do well. They are not hospitalized, and they remain at their home and get these treatments as an outpatients. And these are all biologics, and these are monoclonal antibodies against the spike protein that I had mentioned earlier. These antibodies bind and basically block the further infection from COVID-19. So early on, these are the landmark trials that actually changed the treatment options for inpatient management. These are remdesivir. We are now swaying away from it because we have now biologics, the anti-inflammatory I mentioned. And again, steroids, they improve outcomes, and they decrease mortality when are given as an inpatient. And these indication is, again, not for everyone, only if dexamethasone, if they are requiring higher amount of oxygen. And we have treatments, we have imaging, we have technology. So what's important to a clinician, especially in the ICU, is how did the patient feel? How did the families feel? During this pandemic, as you know, nobody was allowed to go to the hospitals, and patients were by themselves. They felt the stress of the workers, and they did not have anybody to hold their hand from their family members. So I will share a story with you. I had a patient who was on the floor, decompensated respiratory failure, and came to the ICU. Now I had to call his wife that he is intubated, and on the other side, she is crying hysterically. And she said that my husband walked 40 miles to propose me, and right now he is in a coma and I am not with him. I am unable to hold his hand. And I was holding my tears on the other side. And we were using FaceTiming. We were using technology that was available to update families. In this isolation, I had a young lady, had 2 children, struggling to breathe, and she could not be in isolation. And in the middle of the night, she called, she said, I can't be here by myself. I need my family, I need my children. And I educated her, no, you can't go right now. And she said that I was raped 10 years ago, and being by myself reminds me when I was in the hospital at that time. And after much discussion, she chose to go home. And be mindful, like during this time when patients are isolated, there are delays in their care, there are large volume of patients, and they are having complications at the same time. There is collapse of the lung going, and people are having stroke, they are having arrhythmias. So there were the staff, they were distressed, but it was in the middle of all this, it was very important to be mindful of how the patient felt. When there was time to hold the patient's hand, we did it. When there was time to pray with them, to soothe their burden, we did it. And those small things can make a profound impact. At this time, I had another patient. That's her CAT scan. Imagine being by yourself, no family at the bedside, you're wearing all kinds of gear, you can't hear, you can't breathe, your mouth is dry, your nose is bleeding, and this is what you're fighting. So I have a CAT scan here. It's a normal CAT scan. These are the lungs, and this is your trachea, and this is her CAT scan. And this was my patient. And I told her that I am with you. We are giving you all the best possible treatment that we can provide, and let's fight it together. And she passed away. This patient, again, this patient had ivermectin in his hand, and he said, I want to get better. He wanted his family next to him, and his son, he said, he has more ivermectin, you have to give it to me. And again, after much discussion, we have to follow what's working, what's not working, what evidence shows. And this patient had risk factors. He had defibrillator here. He's a heart patient. And these patients, their families are not at the bedside, couldn't breathe. And the treatments that we had are limited. And so what makes a big difference, profound, is human touch, being with them as much as we could. Again, the nurses, they were there. We were there. And the isolation we didn't see just in the hospital. We saw it in nursing homes. And now, what we do is, if the patient's airway is protected and families are allowed to come in, they can see their loved one across the window. And even though it's a simple gesture, but it's profound. So, and this is not just hospital. You experience this everywhere, including nursing homes and long-term acute care. So there was a roar in medical journals in 2020 and 2021. Families have to be at the bedside. We know, we got to know more about what works, what doesn't work, how the masking is important. So we make sure the families are at the bedside for people who are not as sick and they are vaccinated. And also, if their loved ones are intubated, families are across the window, are able to see their loved ones. So there is a glimmer of hope. We saw in 2021, January, we have vaccination available to us. Despite a lot of obstacles, delivery, storage, and public trust, unfortunately, vaccinations are the key to fight this pandemic. And here I highlight a cartoon for you very quickly. Basically, RNA is packaged in a lipid molecule. It was done right here in our armpit at University of Pennsylvania. Dr. Drew Weissman, who basically, with his colleagues, helped create vaccination. And Dr. Lakshmi, he will be your maybe next speaker in the future. And what a great, would be opportunity for students to meet Dr. Weissman. And so basically, you take this RNA that makes the protein, spike protein, you give it in the muscle cells make the spike protein, and then your body says, oops, this is something foreign, let's make antibodies and kill it. And you make antibodies. You don't just make antibodies, you make memory cells. you make memory T cells, and when you are exposed, you are able to fight this infection. Definitely, there are breakthrough infections, but those are not as severe where you need hospitalizations or not so severe of a symptoms. So Dr. Paul Offit, he was here, one of the speakers, and I have been following him. His slogan is, you know, we can do boosters, go with the boosters. If you can get booster, get boosters. Please get boosters. But vaccinate the unvaccinated. So to fight this pandemic, we must vaccinate the unvaccinated. So if we don't have, you know, vaccination at a level that we require immunity from this pandemic, we already have seen many, many variants, and variants are clever. They are making changes at the delta, at the spike protein level, and the delta is the one. There is no escape from it. So vaccination is the key. If we don't, there are many more that we don't even know that are not mentioned in the media, but they are on the horizon. So please be advocates for vaccination. So what did we all learn from all this? This pandemic, what taught us is we had never seen a global collaboration before like this. So as there were surges in Italy or surges in China, there was ongoing research was shared throughout. COVID-2 genome was shared through public media. It was tweeted and it was globally available. So we have birth of vaccination within a year. Mostly it takes, as you know, more than 10 years. So research, technology, public health measures, lockdowns were done globally, and we all participated in it. We all followed. This was all possible through education. This was only possible through education. One of my professors says that we learn and we grow. And I say we survive, we learn, and we grow. What's very important for us is to be ready for future threats, be ready for future unexpected pandemics. And here I have a quote for you. This is very pertinent. It was shared by Sister Carol. In 1998, she said, education prepares you not simply to pass through already existing gates, but to build new passageway to a new and more compassionate tomorrow. It was pertinent then, it's alive today, and it will remain alive forever, Sister Carol. I thank you for promoting education and service to humanity. And thank you. Oops. It's great to be here. It's an honor to be here. Thank you, and I hope that we all continue to help each other, continue to promote education, and I want to thank all of my faculty who are among us today, and all our professors in Chestnut Hill College, teachers and professors, and for promoting education. This pandemic and fighting against pandemic, education is the key. And thank you. Oh.
Sister Carol, would you please come to the stage and then present a token of appreciation to our speaker, Dr. Gayas, and also say your grace and blessings as we move forward. Thank you, Sister.
Please accept this small token of our appreciation. I know it was a great sacrifice that you came today and are driving all the way back to New York tonight, but thank you for truly being a COVID hero. And the more I learned about your story today as I talked with you, you are an inspiration to me, Aisha. Really, what you have accomplished, what you have done, your grit, your love, your care, your selflessness, the obstacles that you overcame to get where you are today. You truly are a hero. And if we just take a moment to thank God, the unnameable one, the God of many names, the holy mystery who dwells within us, around us, among us. Bless our relationships. Bless the time we will spend together after this lecture. Bless the food we shall share. And may the conversation that we have nourish us in mind and spirit, so that we may serve others with justice and compassion, and serve you selflessly with an undivided heart. Amen.
I didn't match her. She matched it, the garland. Perfect matching. I never spoke with her what she is going to wear.
But I saw the picture, so I wore the same suit. And the same pearls.
Wonderful.